All right, guys, we'll get started. Thank you for having us out here today. My name's Will Ferguson. I'm an ER doc out of Birmingham, for those of you here. The ones that moved up front, I got your challenge coins. If I didn't get them to you already, I'll get them to you, okay? So we'll get started. I know Chief Ward kind of gave you the heads up. We have a pretty good online crowd today. Usually average about 300 to 400 people. So if you have a question, just raise your hand. We can do that. It's super laid back, okay? Thank you for almost smiling. Good, good, yes. All right. Do what? Can the volume go up any louder, Chief, for in here? All right, yeah. So I think we're maxed out. All right. So EMS Challenge is a physician-led Con Ed we started about 10 years ago. Super glad for the support of the Fire College and what they do for us. This is just a picture of their director I like to show. Great guy, does a lot of good stuff for us. What I want to kind of talk today, there's a saying in medicine that says, if you hear hoofbeats, it's probably a horse, not a zebra. And so in medical school, they teach the docs and the residents to look for things that are common and rule those things out first. And in reality, in medicine, emergency medicine, pre-hospital medicine, that's not what we should do. Okay, we should rule out the things that kill people, right? So one of the topics I gave at FDIC last year was forget the zebras, it's the hippos that kill. And I think that lecture kind of bombed, so I'm gonna try to redo it for you guys today, okay? Yeah, thank you. All right, so hopefully not too much inappropriate humor at least. But who we are, we're years ago we started with Jeff State, some of the leadership there, and a group of physicians to bring physician-led Con Ed out to EMS. The work that you do in EMS is physician-level care, regardless of what people say. You're doing things we don't let our residents do without an attending physician there by their side. So we should be out there helping you guys. So we are going to be in Birmingham back in June. We do the second and fourth Wednesday. We're at Station 1 in June. We're at Sand Mountain Park. I think it's Albertville, the fourth Wednesday in June. We're taking July off, and then we're back in August, back in the Brims region again. But our schedule should be posted on the Fire College webpage, and you can follow us online or live. All right, so well, I talk about hippos. Hippos are the things that kill you in the jungle, right? Horses aren't going to hurt you. Zebras, no clue what they do. They're cute at the zoo. But I want to talk about things that kill people so we don't miss those things, have a bad day. So Chief mentioned your Con Ed. You can use the QR code that's in the chat box or on your table. You can also email us at Alabama EMS Challenge at gmail.com. We offer medic, nursing, physician, CME, whatever you need, we got it, okay? And it's all free, no charge, thanks to our sponsors. All right, so the first case, 78-year-old male at Legacy of Hope Nursing Home. Y'all got one of those up here in North Alabama? Well, good, I'm not gonna offend anybody. Good, great. All right, head laceration, they said he had done fallen out, DFO'd, so he maybe syncopized, maybe had a mechanical fall. So what do we do for these guys when we get on scene, right? We're gonna do a primary assessment, make sure there's no weirdness going on with the scene. We're gonna do our ABCs while getting a pertinent history, okay? So what things history-wise should we ask somebody at a nursing home or ask the staff on somebody that's fallen and hit their head? Are they on a blood thinner? Perfect. Yeah, that's the first thing I'm thinking about, right? Because that puts them at a higher risk for having a head bleed, and that kills people, right? That's a hippo, not a zebra or a horse, right? What other questions we're going to ask these guys? Yeah, so mechanical fall or not, right? So syncope versus mechanical fall is super important, right? We all have mechanical falls. We're concerned about traumatic injuries, head injuries, things of that nature. But syncope throws you in a category of things that are bad that can kill people. So excellent question. Yeah, mechanical fall. My practice, though, folks that are older, mature, maybe if they have underlying history of dementia, if there's concerns about the care they're receiving at home or a care facility, I'm not going to trust them. So if he had a mechanical fall and he tells me that, I'm still going to think in my mind, yeah, he's 70 years old with a head bag. Maybe he actually syncopized, right? Because that could hurt someone if I miss it. Cool, exciting. Anybody from Tennessee? The Tennessee fainting goats, those things are funny. Anybody have any? I'm not going to raise my hand then. All right. So heart rate's in the 80s, blood pressure is 160/78. He's breathing 22 times a minute. Stats are fine. What's another vital sign I didn't put up there? We got to get on anybody. Blood sugar, yeah, your glucose, right? It gives you a lot of information. In the Deep South, what I'm looking for, if it says low, I know what the problem is. I can fix it. If it says high, I know what the problem is. I can start working on it. Anything in between doesn't matter, right? So between 60 and 350, it's just being an Alabamian, right? Cool. Stats are fine. The guy is neuro intact, so I'm gonna make sure he can move everything. There's not a stroke going on with this guy. They say he has frequent falls. They also say that he's had a recent GI bug, lots of diarrhea, and been vomiting some. We've already kind of talked about the medications, all right? Important question to ask is, are you on blood thinners? The other thing to think about is anybody that's had recent nausea, vomiting, diarrhea, could be dehydrated. Any medicine they take normally can get to higher levels in their blood because their kidneys aren't working good because they're dehydrated. So if they're on a beta blocker at a normal dose, but they keep taking their medicine, but are having copious diarrhea and not taking fluids in, you're going to get more of that beta blocker effect on their body because of that. So it can cause all kinds of issues. Cool. So is this a horse, a zebra, or a hippo? What's going on with these guys? The other thing to think about in nursing home is what kind of information can you get? Who here gets great information from your long-term care facilities? Raise your hand if you do. Right, so it's challenging, right? A lot of times there's issues with documentation. Sometimes there are language barriers. So it's tough to find those things out. And I'd argue that a lot of folks in long-term facilities have some underlying dementia, and getting the history from those guys is super challenging. So lots of causes of syncope or falls, medication changes. We kind of talked about some of that. Anxiety can make people pass out and trip and fall. Dehydration from lack of PO intake. Oh, hey, hello, ma'am. Now I can't even think straight. Dehydration, change in pain medications, older folks that now have a broken ankle or a hip or costochondritis, they're on Norcos or something, can make them get dehydrated. Anything that causes a decrease in cerebral perfusion can make you pass out and fall, right? And sometimes the thing that makes you pass out and fall is more scary than the actual fall itself. Cool. One of the cornerstones of managing somebody and figuring out what's going on with somebody that syncopizes is getting a 12-lead EKG. A 12-lead gives you a lot of data, and there's no risk to it. You're not going to hurt somebody. You're not going to give them radiation poisoning. Okay, the only risk to doing a 12-lead is you got to look at it and make a decision. Is it normal, abnormal? Is it a problem? And what do you do with it? And as a paramedic, you should be able to read a 12-lead and interpret that. I know we got some guys that are in their initial education now. We don't expect you to read a 12-lead before you graduate, but once you graduate, you should be able to read. Yeah, okay. So y'all can look at that 12-lead. We'll come back to it in a second as well. Scary, not scary? Cool. So the way I look at 12 leads, I look at them pretty simple, right? I'm just a guy from Mississippi. I'm going to say, is that ventricular rate too fast, too slow, or okay-ish? I use the rates 50 to 140-ish being too fast. I like American Heart. If it's too fast, I say, is it wide complex or narrow complex? And then is it regular or irregular? I think that's a great algorithm, okay? For too slow, I think of three things that make you bradycardic. Three things you can not pick up in your primary exam. All right, that's drugs such as beta blockers or calcium channel blockers, antiarrhythmic drugs. Electrolytes are really electrolyte. What electrolyte can make you bradycardic? Anybody know? Potassium, fantastic, right? And then ischemia, where they're having a big heart attack, a STEMI or an NSTEMI. Those three things can make you bradycardic, and you won't necessarily pick that up on your primary exam. So if you have a guy that's shot in the belly, he's mad, calling your mama names, heart rate's 140, en route to the hospital, he starts bradying down. He goes 140, 120, 90, 70, 50. That's his heart rate. What's going on with him? Good, bad? He's dying, right? Hemorrhagic shock, his volume loss. You should pick that up on your exam, right? The 9-month-old kid that you pull out of a pool that's blue with a heart rate of 50, why are they bradycardic? They're hypoxic, right? Everything else that you can't pick up in your primary exam is one of those three things. And if the rate's between 50 and 140, it's okay-ish, right? And those are the scarier ones. That's the STEMI, the NSTEMIs, some toxins, maybe hyperkalemia sometimes, infection, and then some toxicology issues. When you look at a 12 lead, you should be able to, is that me making that noise, Chief, walking around? All right, sorry, I'll try to be still. My caffeine titer is kind of high though. So know how to calculate a rate. I know the machine gives it to you, prints it out. Don't trust your machines. I use the box method. If you have calipers, if you have another way, no harm, no foul, but always have a way to calculate your rate on paper, right? So I use the box method, 300, 150, 175. After that, I start thinking about going fishing or having a soda. And when I wake up again, if I'm still counting boxes, the rate is way too slow, all right? The next thing you got to understand is intervals. You got to know your QRS. If you don't know what a Y QRS complex is, you can't determine whether they're in V-tach or a Y complex tachy or a narrow complex tachy. What's the significance of a PR interval? What does a long PR interval tell you? Anybody care? Anybody still awake? Yeah. So classically, we're talking. And a wide QRS, though, in Alabama makes me think of hyperkalemia, and that can be a lethal dysrhythmia. And you got to know your QT interval. QT interval, prolonged QT can lead you to have runs of torsades. Runs of torsades where you syncopize because of decreased cerebral perfusion and you wake up, we call it syncope. What do you call a run of torsades where you stay in torsades? Anybody know? You call it cardiac arrest, right? That was kind of funny. I'm having a hard time with the humor today, Chief. Sweet. All right, so this EKG, too fast, too slow, or okay? What do y'all think? Yeah, I say it's okay. So the machine says the rate is 73, but never trust the machine. So I'm going to go 300, 150, 175. So between 70 and 80, so the rate's okay. The next thing I'm going to do is I'm going to look at injury patterns. I'm going to look at 1, AVL, and 5 and 6. Those are my lateral leads. So I'm looking for ST elevation. Any 2 leads with ST elevation greater than 1 millimeter is a STEMI. Diagnosis made. I'm talking to the hospital. They're going to a place that has a cath lab or a place they can lyse them. The next place I look at leads 2, 3, and AVF. All right. Those are my inferior leads. Same thing. Elevation and 2 leads is the STEMI. T-wave inversion, ST depression is concerning for ischemia, but it's not a STEMI yet, right? The next place I look is V1 through V4, and I'm looking for elevation, 1 millimeter or more, concerning for a STEMI. And then you can also look for T-wave inversion, ST depression. The difference in these leads is T-wave inversion, ST depression leads 2, 3, V2, 3, and 4 is signs of a posterior infarct. So that is a posterior STEMI to proven otherwise. A lot of textbooks, people talk about doing a posterior EKG where you put the leads on the back and do that. That is, my opinion, not for EMS, and that is not for me as an ER doctor. If I have someone that makes me uncomfortable to the point that I'm getting a 12 lead on them, and I've got T-wave inversion, ST depression in any of those leads, V1 through V4, I'm talking to cardiology, and they can decide are they having a heart attack or not, and they can decide it by taking them to the cath lab. That is a high-risk patient. The next place to look is lead AVR. So classically, we were taught that lead AVR is only good to determine if your leads are on correctly. If you're up in 1, QRS complex points up, and you're down in AVR, your leads are on right. In reality, if you get ST elevation and lead AVR and you get depression anywhere else in a pattern, so up in AVR, down in 1, AVL, and 5 and 6, that's concerning of a left main issue disease. Could be a STEMI. If you're up in AVR and got T-wave inversion, ST depression, and leads 2, 3, and AVF, that's potentially a right coronary occlusion. So AVR tells you a lot of stuff. You can also pick up some TCA overdoses. You can also use it for other things. We won't get into much detail with that now. But the 12 leads are a great screening tool for madness, especially in syncope, okay? Once I go through my ischemia patterns, I go look at lead 2, and I'm looking for my PR interval. I look for my QRS interval and my QT interval. My QT interval should be half of the R to R complex, the big peak waves, right? If my QRS complex is narrow, I go one more time looking for injury patterns to make sure I'm not missing a STEMI because some days I've been up way too long and I'm tired. If it looks good, then I put it down. If my QRS complex is wide in V2, I go to V1, all right? And I'm looking to determine now, is this a left bundle branch block or a right bundle branch block? So on this one, I would say that the rate is okay with 300, 150, 75, around 100, okay? I'm looking at leads 1, AVL, and 5 and 6. I got some Y complex cure. Makes me uncomfortable at V1 and V2. All right, I go to AVR. You really can't see it on the slide here. So then I'm going to go over to the lead 2. P interval is reasonable, QRS is wide. So I'm going to go over here to V1. And I got a downward deflection in V1. So now I got a left bundle branch block. And that's important, even as an EMS provider, because that kind of gives us some data to determine, is this person having underlying heart problems in this left bundle branch block? Cool. So what is a left bundle branch block and what causes one? Anybody know? Anybody care? So a left bundle branch block is where you have delayed conduction to the left side of the heart. It's usually due to chronic problems. So chronic hypertension, underlying heart disease, congestive heart failure makes your heart get larger. When the heart gets bigger, it gets more muscle tissue, and it takes longer for the electrical impulse to go through there. So if they have a left bundle branch block, you can assume they have some underlying heart problems at baseline. The question is there new heart problems, something that needs to be intervened immediately or not? We can use something called Scarbosis criteria to look at an EKG to say, is this new or not new? I would argue, though, anyone with a left bundle branch block that looks ill, they're altered, the hypotensive, chest pain, diaphoretic, we assume they have an underlying heart problems acutely because of that new or presumed new left bundle branch block. Cool. So left bundles, Y complex QRS. There's a lot of data out there. You can figure these things out to figure out what's a left bundle, what's not. My advice is find the rules that you like. What I do is I use Y QRS greater than 120, and I'm saying a downward deflection of V1. There's some other criteria, but as a screening tool, that's a great way to know it. And I think as advice for the new medics getting out there and starting, that's the best way to kind of get that down so you understand left bundle. And as you progress and see more 12 leads, you can learn some new rules. But that's a safe way to call it. Scarbosis criteria is a way to look at a 12 lead that's got a left bundle. The machines, whether it be a Zoll, a Life Pack, or the Tempest, whatever you're using, if it sees a left bundle, it's going to stop interpretation. It's not going to tell you is there a STEMI or not a STEMI going on. It's going to say left bundle branch block for the most part. So you as a medic should be able to figure out, is this a new acute STEMI going on or not? And you use Scarbosis criteria. The mainstay of this is that ST elevation in the direction of the QRS complex is always a STEMI. So if my QRS complex is pointing up and I got ST elevation pointing up, it's a STEMI in any lead. In the posterior leads we talked about, V1 through V4, if I got T-wave inversion, ST depression, that's a STEMI. Nothing changes. The gimme we get is in lead V1 through V4, we get one big box instead of one little box. So discord is good, all right? So back to this 12 lead, we got ST elevation leads V1 and V2, but I've already gone through this and I recognize this is a left bundle because I look at lead 2 and I say Y complex QRS, V1 points down, so I know it's a left bundle. So when I look at V1 and V2, I got ST elevation of 1 millimeter, which is small, not one big box. So this is not a STEMI equivalent. Doesn't have to go to the cath lab hospital. Does that make sense? I got some I's crossed. The way you get better at 12 leads is you look at a lot of them. If you're working for an agency where you're not seeing more than 50 or so a month, you got to look at more, okay? So Wave Maven's a great resource. Life in the Fast Lane is an online resource. There are YouTube videos out there. You got to know normal so you know abnormal. Once you learn that, you got to realize what is STEMI, what is not STEMI. And once you get that, you got to be able to recognize left bundle scary or left bundle not scary. So this one here, too fast, too slow, or okay. The rate. So 300. One AVL, 5 and 6, 2, 3 in AVF, V1 through V4, 1 in AVR are opposite. So I go to lead 2, QRS is wide, so I'll go over to V1. I'm pointing down, so it's a left bundle, all right? So is that a concerning left bundle or not a concerning left bundle? Who says concerning? Raise your hand. I got one person. Who says not concerning? I got no hands. Who's not going to vote? Raise your hand if you're not going to vote. Good. True Americans. I like y'all. Good. Yeah. God bless America. Right. Yeah. You got to vote, guys. Come on, man. So I would argue it's a left bundle, but it meets Scarbosa and it's super scary. So if you look at leads 5 and 6, we got ST elevation in the same direction of the QRS complex. That's the STEMI in a left bundle or a right bundle or no bundle, okay? If you look at leads 2, 3, and AVF, we got discord, so those aren't super scary, but 5 and 6 is enough for me to say, hey, machine says it's the left bundle, but me as the medic, I recognize this patient has ACS symptoms, they're diaphoretic, they got some shortness of breath. I got an EKG that shows a left bundle, machine's not gonna read it. That's a scary EKG, right? So that patient needs to go to a place where there's cardiology. Go. All right. This one, I'll say the rate is okay. I'm gonna look at leads 1, AVL, and 5 and 6. QRS complex is weird, but no ST elevation. 2, 3, and AVF, same. I go to V1 through V4, and you see you got deep T-wave inversion and ST depression there. Makes me think of posterior infarct. All right. I go to lead AVR. AVR is opposite lead 1. So then I go to lead 2. And I recognize I have a Y complex QRS, so I'll go over here to V1. But this time, instead of that QRS complex pointing down, it points up. So this is not a left bundle, it's a right bundle branch block. And by definition, we know with a right bundle branch block, those T-wave inversions of V1 through V4 are normal. So now I feel better. They get supplemental oxygen, they get aspirin, they get IV access, they get fluid resuscitation, they get a pre-hospital report to the hospital, okay? But my concern for them is less now because I know that is normal in a right bundle branch block. So that's why it's super important to know how to read a 12 lead. And yes, I know we don't get a lot of that in primary education. There's not a lot of that in continuing education, but it's a skill you gotta have as a medic, or people get to the wrong hospital and people will die. Cool. What causes a right bundle branch block? Anybody know? Pulmonary hypertension. Yeah, anything that jacks up the right side of the heart. So chronic hypertension, left-sided heart failure yields right-sided heart failure. Anything that causes increased pulmonary pressure can do that. So chronic COPD use, the guy that's been in the coal mine for 40 years that has lung disease. What can make you have pulmonary hypertension, pulmonary problems acutely? I give you that one. That's a good one. Asthma exacerbation. I like that. I wasn't looking for that answer, but that's a good one. I'll take that. Okay. What else? How about a pulmonary embolism, right? So a PE can put you into a right bundle branch block pretty quick because you got new increased right-sided heart failure. Go. All right. We won't talk about vectors. I have to relearn that every 6 months when I talk to the docs about it. I do more of the memorization for my 12 leads. Don't tell anybody. Go. We talked about causes of right bundle. So right bundle branch block. Go. Wait. The goal of getting the 12 lead on folks with syncope is looking for things that you can find that make them pass out. So if I got an old dude in a nursing home that keeps falling over and you do a 12 lead and you get this on him, could that make someone pass out if they get up and start walking around? Yes. Why? Yeah, it's bradycardic, way too slow, right? Yeah, so complete heart block versus some kind of high-grade heart block, right? Bradycardia. So I'm doing great when I'm sitting there having my cigar watching, Jerry Springer. When I get up to go to the bathroom and I start walking, I put increased heart stress on me and I pass out. Cool. You're looking for these things with some of that syncopise. What about that one? Could that make you syncopise? What's going on there? STEMI. Pass out? Yes, yes. So remember, with syncope, you always get a 12 lead. It's low-hanging fruit. You can usually find the problem with that. If you find the problem, you're a hero. You're making somebody's life better. If you don't find the problem, who cares? You've hurt no one. So 12 leads. So back to this one. Normal, abnormal. Abnormal. I'll say abnormal. Why would I show you a normal one, right? Cool. So is the rate too fast, too slow, or okay? Who says it's too fast? Nobody votes again. Who says it's too slow? Who says it's okay-ish? I'm going to say okay-ish. What's the machine say the rate is? Can y'all read that? Do you believe it's 256? I don't either. How would you find out if your patient has a heart rate of 256 beats per minute? What are you going to do? Yeah, chuck a pulse, touch the pulse. Yeah, reach down. If they're talking to you, they probably don't have a heart rate of 252, right? Yeah, lay hands on them. Cool. So I'll say it's an abnormal EKG. I do my normal, too fast, too slow, or okay. I say the rate's okay-ish. I'm gonna look at leads 1, AVL, and 5 and 6. 2, 3, and AVF. V1 through V4 is pretty jacked up because I got a run of some PVCs or non-sustained VTAC, right? I go look at AVR, looks reasonable when I got a conducted beat. I look at my lead 2, perineal's good. QRS is reasonable, right? I don't really see much of a QT maybe, right? So I'm gonna go down and look at lead 3. And what do you think of your QT interval there? A little bit longer than normal, right? Longer than half the R to R. So we got a guy with a long QT having runs of PVCs, potentially could be torsades, right? Because the long QT leads to torsades. That could be the reason this guy's falling. Now, dude still could have just tripped and smacked his head, but this is a hippo. This can actually kill somebody in the near term, right? That makes sense? And that's how I'll use a 12 lead to kind of help figure out what's going on with syncope. Cool. What causes somebody to have a long QT interval on their EKG? Taking too much QT? That's a joke, QT. Yeah. Somebody smile. Thank you for smiling. Yes, sir. Yeah. What'd you say? Drugs, yeah. Americans again, right? Drugs, yeah. A lot of drugs prolong the QT, right? So any psych medication can prolong it. There are a lot of cardiac medications. Any of your nausea medicines, including the one that y'all carry, Zofran, prolongs that QT. So if I got a dude that's had the GI bug, diarrhea, nausea, vomiting, maybe he's already on psych medications for his advanced dementia. Maybe he's been nauseous and they've been popping him with some Zofran or promethazine or Phenergan, right? And his QT is long. Another thing that makes your QT long is loss of magnesium. And you lose magnesium when you have diarrhea. So I got this older guy, probably on medications, all right? Maybe some underlying health problems, all right? Already on medicines that prolong the QT, and now your mag's getting low. So this guy's high risk for having runs of torsades. Cool. How do we treat torsades? I hear voices in my head. Yeah, so electricity. So if he's in torsades, complete torsades, yeah, they usually aren't talking to you. He gets chest compressions, he gets electricity, right? He gets airway management, he gets epi for the cardiac arrest with no pulse. He also gets what other drug for torsades? Magnesium, good. I thought you were going to say Valium. That's for you, not the patient, right? Yeah. So it gets magnesium, right? So magnesium for these guys. So if I got a guy that's having run of torsades, or these PVCs and a long QT, this is the guy that I'm gonna be thinking, calling med control. Hey, I got a 70-year-old guy that's syncopized. He's got a long QT. He's having run of torsades. He's talking to me with a stable blood pressure now, but I'm gonna give him a couple of grams of magnesium. Thank you. And you hang up, right? And they get magnesium. And that makes that QT get shorter, and it makes them have less risk of going into a lethal dysrhythmia. Cool. So magnesium is the drug of choice for torsades. Cool. And I think this is just hilarious. So I got this video on here like 15 times, guys. So get ready to watch it again. All right. This is a 43-year-old female, passed out at home. Family states they found her on the floor, has a remote history of some migraines and headaches. Per the first engine company on scene, she's got a blood pressure of 190/90, respiration is about 16. What is a normal respiratory rate on somebody? Anybody know? Yeah, so I would say in the ER, when I'm reading triage notes, everybody's got a respiration of 14 to 16, and they're dead, and then you get 0. Or they're complaining of shortness of breath, and they get 24. So my point is, nobody really counts this stuff. You ain't tricking me. Okay, so I would say work of breathing is more important. If I'm checking a respiratory on somebody, I'm gonna be looking at them, watching them breathing. I'm counting for about 6 seconds, and I'm multiplying times 10. So if I count 3 times, 3 times 10 is what, 30? That's too much. If they take 3 breaths in my 6 seconds that I can keep my ADD in control to watch them breathe, that is too fast. They should be breathing about 1.5 times, right? Cool. Respiration 16, heart rate in the 100s, sat 94%, a glucose 116, that is hypoglycemia for North Alabama, right? Cool. All right. She's alert. She's got photophobia. She said, oh, the light hurts my eyes. Okay. Worst headache of her life. Then she kind of like, she woke up. So she passed out with the worst headache of her life. She is neuro intact, moves everything, can talk to you, knows what's going on. GCS of 15. What's going on with this patient? Anybody know? I like that potentially had a stroke. Yeah. I would say it's stroke-ish. Not an epidural, but maybe a subarachnoid, right? So when I'm thinking an epidural, it's more trauma, but blood in the head. So headache and syncope is blood in the head, subarachnoid to proven otherwise. Yes, they're awake and alert, neurovascular attack here now. That's because it just ruptured, aneurysm did, all right? Give them 45 minutes and the situation changes, right? So you'll see a worsening outcome. So cool, yeah. Suspect it, identify, treat it. That is for my doctor friend, the SIT, right? Cool. So subarachnoids, you usually have an aneurysm somewhere in the brain. That thing ruptures, blood outside a vessel in the head hurts. You get a headache. Oh, hurts so bad you pass out. They wake up, the neuro intact, and then in the next 45 minutes to an hour or so, they get more obtunded. Things do not go well. Subarachnoid hemorrhage, super bad. The problem with this is where that bleeds is it fills up the normal pathway of CSF to leave the brain. So you get people that get blood clots in that fourth ventricle. They get increased intracranial pressures. They got to get a ventriculostomy. Or subarachnoid hemorrhage, and that patient should get to the hospital. The way we diagnose this is with a CT scan. Used to be it was a CT scan, then we did a spinal tap, lumbar puncture. Our CT scans work pretty good now. We can find the majority of these bleed. Worsening bleeding, prevent that clotting of blood, decrease outflow, prevent that increased intracranial pressure, and potentially save a life now. For 10 years ago, that was less the chance. So treatment, early diagnosis is the key. So if this is your patient, when you get to the hospital, what you're going to do is after you get triaged in, you get screened, you smile, you go find that physician, say, hey, doc, I got a 43-year-old lady who had the worst headache of her life and passed out. I think she's got blood in her head. A reasonable ER physician would get up and go see that patient and make their plans and get things moving. If you say, I got a 43-year-old female with a remote history of migraines with a headache that kind of passed out, nobody's going to be moving fast. Are there any issues with wall times seeing patients here in North Alabama? Probably not, because y'all are cool, right? My point is, if you have a risk factor for a patient that can have a bad outcome, find that doc. We get it. We know everybody's challenged with patient issues, boarding, all those things. Let us know your concerns. We'll get up, go see that patient. If we agree, we start that workup right then. If we don't, you're off the hook. You did your job. Cool. All right. Supportive care. These guys, after we get that CT scan and we know there's blood in the brain, we can start addressing the blood pressure. We don't treat blood pressure pre-hospital or inter-facility without a CT scan. If this was an ischemic stroke, like you had mentioned, or non-bleeding stroke, we want that blood pressure high to perfuse the brain. If there's blood coming out of a ruptured aneurysm, we want the blood pressure lower. Okay, so after the scan, we do blood pressure management. Neurosurgeon can go in and coil these aneurysms. Sometimes I got to put shunts in as well. There are ways we can manage these if we recognize them early and get them to the OR fast. If we recognize that 6 hours later, when they're seizing and posturing, damage is done, we can't fix it. Cool. That's the CT scan, just a quick pic. When you think about a CAT scan, if you're looking at them, the patient head is into the wall, their feet are coming out, and they're looking up. The gray stuff is brain, white stuff is usually fluid or blood. There should not be blood in the head. We call that the star of death. Big subarachnoid. Got to be managed quickly by neurosurgery for that person to go back to a normal life. Cool. All right. Who likes cats? Cat person, raise your hand. All right. Now we got people voting. Good. Dog person. All right. Who likes goats? Oh, I got one. Good. There you go. I like you already. This is good. They taste good. Killing me. So we got a young lady, 60-year-old female, was playing in the yard with her grandkids, running around. She passed out. Family states that they did chest compressions for a minute, but now she's awake and alert. She's got no complaints except her chest hurts. She's got some bruising. Alert oriented. She's like, why'd y'all call 911? What happened? Okay. So what are we going to do for this lady? We're going to start asking our same questions. Hey, patient, sorry. So heart rate is fine. Respirations are good. We're going to get a 12 lead. We don't see any signs of too fast or too slow. There's no STEMI. Blood pressure is good. SATs are great. She's a diabetic. So we check her sugar. It's 350. Fantastic. Cool. So we do a quick physical exam, which I know everybody does. She's got a regular pulse. She's not sweaty. Blood pressure is good. I'm going to listen to her lungs. The lungs are clear, but she's got a murmur. Is that important? I would say yes. So I'm an ER doctor, right? I can tell you there's only 3 murmurs I get concerned about. If I hear them, a lot of times I care deeply. Of aortic valve insufficiency, like aortic stenosis or an enlarged heart. Usually these guys pass out when they do extra exertion. They get up, they run, they get excited. The heart starts beating faster and it can't keep up with the cardiac output. So this syncope and a murmur is aortic stenosis until proven otherwise. The good news is somebody did chest compressions and got her back alive for a few minutes. Okay, if there was no family there, she would have gone into cardiac arrest and she would have died. This is one you don't want to miss either. So syncope and a murmur is aortic stenosis. And what you got is you got the valves, that aortic valve there, and it gets either stenotic or calcified and doesn't work good, so you can't get the outflow that you need. The other cool thing about that aortic valve is it looks like a prehistoric bird, doesn't it? Doesn't it look like a bird? It does to me anyway. All right, cool. You think it's a bird, Chief? Okay, all right. Next slide. All right, so same case, but it's a 13-year-old playing basketball at the gym that syncopizes. Okay. Folks say that he lost his pulse, did chest compressions for a couple of minutes, then he kind of got up again. What's this kid got? Kids usually don't have aortic stenosis, but when you see on the news about an athlete that passes out while working out at the gym or on a football field or a basketball court, they have hypertrophic obstructive cardiomyopathy, HOCM. And that's where the left side of the heart gets so big that there's not enough space inside of it to pump enough blood out when they do exercise. So syncope and a murmur is bad in adults for aortic stenosis. Syncope in a kid with or without a murmur while they're exercising is HOCM. Those people go to the hospital, they get echoes to figure out what's going on. Because again, if they syncopize with this and they come out of this, it's great. If they don't, it's cardiac arrest and people die. And I bet if you Googled Alabama, there's probably a couple of years of young folks that die from HOCM every year because of this. Cool. So 3 murmurs I think about syncope and a murmur is aortic stenosis or a HOCM. If I have someone that has a murmur and they are febrile and they have a rash on their hands, okay, I'm thinking about endocarditis. Usually it's IV drug users or mental compromised people. That murmur matters to me because those guys need IV antibiotics and echo and inpatient care for a long time. And then the other murmur I get concerned about is if someone's having a STEMI, like we saw earlier, that mount STEMI, and you listen to them, you got cardiac output. So in addition, they need a cardiologist, they need a CV surgeon. So 3 murmurs I think about. Syncope and murmur is HOCM or aortic stenosis. A murmur and a STEMI needs cardiothoracic surgery. And then a murmur and a fever and a rash and an IV drug user is probably endocarditis. The rest of the murmurs are great for testing purposes in school, all right, in exams. But from an ER perspective, don't really change what I do. I care deeply about it, but it doesn't change my care. Cool. Abdominal pain and syncope, I think, again, it's sort of like I do with the head. I think about the fact that acute pain and syncope makes me think massive volume loss from something. because when blood leaves a vessel, it hurts. So in the older population and the folks that have a history of smoking, they're high risk for having aneurysms, abdominal aneurysms. So abdominal pain and syncope in a 70-year-old with a smoking history, in my mind, is an aneurysm that started to to rupture until proven otherwise. Cool. And that's just a forward shot of a CT scan. The white stuff is IV contrast. So that's the aorta coming down there on your left. And that big ball thing that looks like maybe a bladder is actually an aneurysm that is now leaking. Super scary. And the way you diagnose that in the field, the way I diagnosed it in the hospital initially is with a risk factors. So old person, belly pain, syncope, history of smoking. Maybe if they're skinny, they got a palpable mass in their belly. That's not most of the patients we see, but you got to have a high index of suspicion to think aneurysm for these guys. Go. These are guys that once we get the imaging, if you're going from hospital A to hospital B in EMS, these guys, we are going to manage their blood pressure. But again, it's after the imaging. We want to drop their blood pressure as low as we can to maintain cerebral perfusion, to decrease shearing force on those vessels. So we drop their heart rate, drop their blood pressure. We start volume resuscitation on these guys. There's some pretty cool things that the vascular surgeons can do now. They can do some interventional radiology procedures where they put a wire in and then put a sheath or a stent or a bridge over that aneurysm, and it's not open surgery anymore. But if these things completely rupture, people do die, and they die pretty quick. Cool. So when you think about syncope, emergent syncope, craps is a mnemonic you can use. I always think cardiac, get a 12 lead, gives you a lot of data. And you're looking for too slow, too fast, or some kind of weird dysrhythmia, or that QT interval we talked about. Acute blood loss or ruptured AAA. The other thing that you're going to see is you got a young female of 19, 20 years old, of childbearing age, acute onset abdominal pain. Okay, you think potentially an ectopic pregnancy as well, because that thing ruptures, you get free blood in the belly. It can come from ruptured ovarian cyst as well. So blood loss, outflow issues like HOCM or aortic stenosis, pulmonary embolism can cause this, and then subarachnoid hemorrhages. All right, let's talk about 56-year-old fella, history of hypertension, complaint of shortness of breath. He's tachying in 113s. When I do my 6-second respiratory count, he's breathing 3 to 4 times a minute in that 6 seconds. So I know that rate is way too fast. He's saying 88%, blood pressure is 220 over 115. On exam, he's alert but anxious, speaking in 2 or 3 word sentences. When you listen to him, there's no murmur, but he's got gurgly sounds and all his lung fills. He sounds wet. And he's got some pitting edema. What's going on with this guy? CHF, right, yeah. So I would say change that phrase to say from CHF to say pulmonary edema. Lots and lots of people have congestive heart failure and they don't get pulmonary edema. We care about CHF and nothing major fancy I'm gonna do to treat it, but pulmonary edema I'm gonna treat because this guy's symptomatic, right? Cool. So there's a mnemonic that I like, LMNOP for my pulmonary edema. The P stands for position and pressure. So I'm going to sit these dudes up as tall as they can, let them lean forward. That moves the fluid to the lower lung basis so they can breathe through the top part of the lung. And then pressure. What do I mean by pressure? What kind of pressure am I going to give these guys? CPAP. Yeah, positive pressure ventilation, right? Yeah. So you sit them up, the fluid moves to the lower bases. You can aerate the top part of the lungs. If you increase the pressure in the lungs, it decreases blood return back to the heart. So their heart has more time to beat the fluid out of the lungs. So it does a great job. What happens when you put somebody on CPAP to their blood pressure? Does it get higher or lower? Lower. So it works like nitro does too, right? It decreases preload. So CPAP, BiPAP, if you got a ventilator, is great for these guys. Cool. So position and pressure. Obviously oxygen and then nitro. This is the mainstay of therapy. So if I got this guy in the field, blood pressure 220 over 130, pulmonary edema, breathing fast, what I'm going to do first is I'm going to recognize the event, what's going on, diagnose the fact he's in pulmonary edema, he's hypoxic. I'm going to put a nasal cannula on him. I'm going to crank it up to 15 liters. All right, that's oxygenation for this dude. All right, I'm then going to pop a nitro under his tongue to decrease his preload, drop his blood pressure, and then I'm going to get my second tank of oxygen and put him on CPAP. So I got oxygen under the CPAP and nasal cannula, so I know he's getting great oxygenation. I got my CPAP or my BiPAP over that, and I've already popped a nitrile under his tongue. So what I'm doing is I'm rapidly lowering his blood pressure. I'm improving his oxygenation. I'm setting him up, and I'm probably going to fix his pulmonary edema pretty quick. Okay. The M, you can also give these guys some morphine. Why do we give people morphine in pulmonary edema? Because we can. That's a joke. Yeah. Yeah. Morphine is an odor narcotic. It causes a histamine release. It would drop your blood pressure. That's the mainstay. It also makes them feel better. They go from I can't breathe to I can't breathe, but I don't care, right? They say roll tide. Okay. So, and what is the L? What is L we can give them? Lasix, yeah. So most folks, in my opinion, don't need Lasix in the pre-hospital world. The other problem with that is once you give this guy Lasix, a little while later, you got to be breaking out a urinal, or you're going to have a mess in the back of your ambulance. Mainstay of therapy is going to be position, pressure, oxygen, nitro, maybe some morphine. If you get to the L and you need to give them some Lasix, that's fine. Can't say Lasix, sorry, furosemide. I get in trouble. Go. This is an older guy that passed out at Walmart. He's alert, mildly dyspneic, a little bit tacky in the 110s, sat 93%. Blood pressure, he's hypotensive for Alabama. He's 110/60, breathing 20 plus times a minute. Glucose is 214. When you start asking your questions to risk stratify what's going on with this guy, he's got a history of hypertension and COPD. He says his wife noticed he had cellulitis on his leg and made him go to urgent care. So he restarted his blood pressure medicine and his COPD medicine, and he got put on antibiotics for his leg. And his leg is big, swollen, red, nasty looking. So syncopized and all these things going on. What could be causing his syncope? Could be his blood pressure medications he just got put back on, right? He could be septic from his leg, right? He could be hypoxic because he's got COPD and breathing fast, right? Cool. So think about the things that cause that. Get the appropriate history to figure out what's going on with those guys. And then these folks need an EKG, right? So we're looking for low-hanging fruit. Cool. So a little bit tacky. He's got lower extremity edema, swollen legs. He's wheezing throughout. Broad differential. Could be a lot of issues. There's his EKG. Too fast, too slow, or okay. Who says too fast? A little bit too fast. I'll say it's fast-ish. He's in the 150s. All right. When it gets that fast, you're not looking for injury patterns, but my mind always goes there. I'm looking 1, AVL, 5, and 6. I got inverted T waves, depression laterally. 2, 3, and AVF. Yeah, it looks a little irregular, and so they're kind of weird. V1 through V4, you got some posterior changes, and we're up in AVR. So a little bit fast with signs of ischemia, probably due to the rate, right? Cool. So what can make you pass out, get tachycardic, go into AFib, and be hypoxic at the same time if you got a swollen leg? PE, right? So this is almost like a no-brainer, right? It's a gimme, right? Yep, it could be his blood pressure medicine. Yeah, it could be septic. Yeah, don't care. The biggest red flag for this guy is the fact his leg and his syncope makes me think PE, and that will kill him a lot faster than sepsis or other things. So this guy has a PE till proven otherwise. When you get to the hospital, that's how you sell him to the docs. Hey, 46-year-old guy at Walmart, passed out, a little bit tachycardic. Nobody gets excited. Hey, 46-year-old guy at Walmart, swollen leg. I think he's got a PE. He passed out. He's got new AFib. His heart rate's 150. That will make a doc and a nurse stand up and go see that patient and potentially save a life. Cool. So PE. Yeah, exactly. So syncope, dyspnea is a PE until proven otherwise. Cool. The way we diagnose this in the ER is now with a chest X-ray. We get a CAT scan, a CT angio. We can do some indirect methods. Some of you guys are carrying ultrasounds up here. I know that. You can do an ultrasound. You're looking for right heart strain. Okay, that's an indirect sign of a pulmonary embolism. VQ scan, something we did years ago. Those things are pretty outdated, don't work well. Cool. Again, CT scan, the white is contrast going through the vessels. The black is where you got a big PE. Cool. The way we treat this is we recognize it. They get O2 if they're hypoxic. They probably will be. We can do anticoagulation. So if you want to give them an aspirin, great. Roll Tide, do that. They also need heparin or Lovenox and something else from us in the hospital to make that PE not get bigger. It doesn't reabsorb that blood clot, but it makes it not get bigger. All right. They can get fluids for hemodynamic instability. And then we can give them lytics like we do for heart attacks and for strokes, either TPA or TNK. If you work at a place that has an interventional radiologist or interventional cardiology, a lot of times they can go in with a wire and put the thrombolytic right there at that vessel. But from an ER standpoint, we can lyse these guys and salvage them. So, all right, we're about out of time. I'm gonna bypass my trauma humor this time. We'll catch that next time. Questions, comments, statements within reason.
Hey, Doc, we did have a question. Somebody says, hey, we carry fentanyl, not morphine. Is there any value to giving fentanyl for pulmonary edema / congestive heart failure?
Yeah, I mean, you can if they're hurting. It really has, fentanyl doesn't drop the blood pressure, and that's the main goal of the morphine is drop the blood pressure. So if you drop the blood pressure well with the CPAP or BiPAP and the nitro, and you're doing fentanyl because they're anxious and agitated or hurting while you're trying to keep the CPAP on, then go with the fentanyl. That's fantastic, but it should not affect the blood pressure.
Very good. So ketamine's a definite no in that circumstance, right?
So I would say no, because the problem is if you get that dose wrong, you're going to make them not breathe well, and they got to breathe to ventilate, right? Ketamine is a great drug for bronchoconstriction, for asthma, for COPD, but you got to be wise because a little bit too much and the breathing slows down and they get worse. So that's a discussion with your offline medical director and the state.
Could ketamine also prevent the blood pressure from lowering as much as we'd want it to? Isn't there some?
Correct. Right. Yes. It would increase the blood pressure, which is counterintuitive of what you want to do. Right.
Got it. Anybody in the room have any questions for Dr. Ferguson? All right. Thanks for that great lecture, Dr. Ferg. You got anything else before we go to break?
Okay. Let's take a break.
Yeah, we'll take about 5 minutes. Everybody online, stay tuned. We'll be back with Dr. Adams. For everybody live and in person, please make sure to fill out the attendance form. There's a link in the Q&A box online, or there's a QR codes to scan here in person. The password for the attendance form today is stroke, all lowercase, the word stroke. And we'll be back here in just a few minutes with Dr. Adams. All right, and welcome back, everyone. We're lucky to have Dr. Adams with us today. She's a UAB Chief Resident in Emergency Medicine right now, and she's going to be talking to us about stroke.
Okay. So thanks so much for having me. I'm Delana. I'm really excited to be here. Really glad we have such a good turnout today. So how many of you feel really comfortable managing stroke patients? I don't know if nobody's voting because they don't feel comfortable or because y'all don't want to vote. I feel like this is kind of an area that sometimes gives people some anxiety. So hopefully this can make y'all a little bit more comfortable after we talk through some things today. So we'll just go ahead and get started. So why does stroke matter? Stroke is super common, y'all. So all of you will take care of numerous stroke patients in your time in the field. Every 40 seconds, someone has a stroke in the United States, and every 4 minutes, someone dies from it. And so that's a huge number. And 1 in 20 deaths in the US every year is from stroke. Here is the Alabama data. Patients entered into the stroke system in 2022. As you can see, there was almost 10,000 patients entered just for that year. If you look on this map here, this kind of shows you incidence of strokes throughout the country. And of course, Alabama is dark purple, meaning that we have tons and tons of strokes around here. So this is something you really need to know how to do, and you need to know how to do it well. And so that's why we're talking about it today. So who can tell me the two big types of stroke? Ischemic, I think I heard, yes, and hemorrhagic. Ischemic stroke obviously is a clot causing ischemia to the brain. Hemorrhagic, also self-explanatory, some bleeding to the brain that's causing the stroke. Which one is more common is ischemic. So 87% of the time, the stroke is going to be an ischemic stroke. So we'll focus more heavily on ischemic strokes today with a little bit at the end about hemorrhagic strokes as well. So who can tell me the two big types of ischemic stroke? So it's going to be like large vessel occlusion and smaller vessel occlusion. So large vessel occlusion is going to be your internal carotid arteries, middle cerebral artery, or your basilar artery. So those are kind of like your big ones. And then you have your small vessel occlusions. It's really all the others that we're calling, for focal neurologic deficits. And so it's super important to distinguish between the two because the treatment does differ. So patients with large vessel occlusions actually have, the option to potentially get a thrombectomy. And so that only happens at certain places. So we have to know who needs to go there, right? And so that's why it's super important to actually know who is having a large vessel occlusion versus who is, can just go to like a regular stroke center. And also, if you're having a large vessel occlusion, you're much more likely to have significant morbidity and mortality associated with that. And like I kind of put on the beginning slide, time is brain. So this is kind of astounding. Every patient who's having a stroke, typical patient, will lose around 2 million neurons every minute that they're having that stroke, okay? So huge efforts are put into getting these patients to where they need to go quickly. So what are y'all going to do for these patients? You show up, you're having a patient who's telling you, they're having some sort of focal neurologic deficits. Kind of what are the things that you are going to be doing for them? Say a little louder for me. Yes, HEMSI. You said fast exam? Okay. Anything else? Blood sugar, yes, definitely. So big things that you want to be, information you want to be collecting and things you want to be doing, HEMSI for sure, which we'll talk a little bit more about, all the components of HEMSI. Last known well. That's super important also for treatment purposes. Based off of when their last known well time is, we know that we can give lytics if it's early enough. And so that's something that the information we really need to gather from, family that's there or the patient if they're able to talk to us. Other things that often I feel like this is the thing that probably gets missed the most is a contact number. If there's someone around, just getting their phone number is super helpful because once they get to the hospital, we may not be able to get in touch with anyone. And if the patient isn't able to answer questions, that can delay their care while we're trying to find a way to get in touch with family to get, consent for different things. So that's super important as well. And then there's also a checklist, which we'll talk a little bit more about the importance of that too. So HEMSI, the first part of HEMSI is eye movement. Can anyone tell me exactly what you're going to do to assess the patient's eye movements? Exactly, yeah, so I got a bunch of that. So what you're going to do, you're going to have them follow your finger, across right and left, not moving their head, right? We're not doing this. Only their eyes to make sure that they can actually look on both sides of their body. If they're only, following your eyes or following your finger with their eyes on one side, obviously that's abnormal. What if they're not really, what if they're just kind of looking to one side? They're alert, but they're looking to one side. What are you going to do? Yeah, so you can go to that side. You can call their name. So you can call their name on the side. And then on the side that they're not looking to, you want to see if there's a difference. I've seen a lot of our neurology residents will clap really hard on the bad side and the good side to look for the reaction. Because sometimes they're just not interpreting the information. And so maybe they'll actually kind of look towards you if you're like clapping or making kind of a commotion over here versus over here. And you can kind of assess whether or not it's abnormal that way too. So what about motor? What are we going to assess motor-wise? Smile, that's good. What else? Yeah, extremities, yes. So arms and legs. So what are we going to ask them to do to assess their, their facial motor function? Big smiles, yeah. And not just like a little tiny like smile. You want to say, show me all of your teeth. Because sometimes people will trick you and they'll, give you like a little tiny smile and you think that it looks maybe symmetrical, but then when they smile really big and you look to see their teeth, you can actually see the facial droop. So get them to smile big. Obviously, if it's asymmetric, it's abnormal. And then arm weakness. So assessing for arm weakness, we're gonna, obviously have them hold their hands up. and ask them to close their eyes and hold them for 10 seconds. If one of their hands is kind of falling down, then that's abnormal. If they're aphasic, you can just pick their arm up and say, I'm going to hold your arm up. I want you to keep it up, and see if they can do it that way. And that's how you can kind of assess for symmetry there. And then legs, very similarly, gonna, have them pick their leg up for, a few seconds, and see if they can hold it there. And if they're not really doing that when you're asking them to, you're gonna pick their leg up for them, hold it up and say, I'm gonna hold your leg here. I want you to keep it there when I let go, and see if they can hold their leg up. Okay. And then how are we gonna assess for, their speech and aphasia? Okay. So we're going to ask them to name a couple things. It doesn't have to be watch and pen. I saw in like the stroke video, they did like ring and watch. So if you can't find your pen, or, it's okay. Just give them something that's a common item that at UAB, I've heard them say, like, today is a sunny day in Birmingham is their phrase for y'all. It says they heard him speak on the radio last night. Just make sure that you know which phrase you're going to be asking, or it's kind of hard to do the assessment. And then you're kind of looking for your card, trying to figure out, you shouldn't really, you should have this memorized. You should be able to do this because you're going to encounter a lot of these patients. So you're going to have them speak after you to see, number one, are they able to interpret that you're asking them to kind of do that? Sometimes they'll just be kind of like looking off because they have like a receptive aphasia. They're not really understanding that you're asking them to do things. They can't follow those commands. Or are they just having really difficulty actually getting the words out, like an expressive aphasia? And so this will kind of help you kind of see that. And then as well as, naming the pens and the watch, that'll kind of help. So who can you use HEMSI for? Or better question, who can't you use it for? So they have to be able to participate, right? So there's kind of a little rule that you can use: alert, verbal, pain, or unresponsive. Like, how responsive are they? And so that's kind of like a spectrum of what their level of responsiveness is. And so if they're alert, or they're, verbally responsive, you can use this. If they're only responding to pain, like you're having to squeeze them to even get them to open their eyes, they're not real, they're, so have such significant deficits that they can't really participate in the exam, then you can't use HEMSI because it's just not going to be effective for them. Also for unresponsive patients, obviously they're not going to participate, so you can't use it there either. At that point, if you think someone might be having a stroke, it's going to be up to your discretion to enter them into the stroke system. Some ways that you can kind of assess these patients who are responding to pain, you can kind of squeeze all of their extremities and see if they're, withdrawing on a certain side and not on another side. Just, look at their pupils, see if they have evidence of, pupillary abnormalities, things that you can do to assess them. But you won't be able to use HEMSI to assess them. But at that point, it'll be at your discretion to decide if you think that they're still having a stroke and need to enter them into the system. Last known well time. Does this confuse anyone ever? It confuses me sometimes because there's, all these different things, like families telling you multiple different ways that they've talked to the patient, and you don't really know when they were last well, or nobody's seen them, for however long. So we'll go through a couple of examples, and I want y'all to tell me what you think the last known well time is. And so let's say that we have a patient who woke up at 6 o'clock this morning, and they had right-sided weakness. Can you tell me their last known well? Yes, I see last night. So it's whenever they went to bed. And so that's usually kind of a tricky thing. I've had that told to me many times where patients are brought in and they're like, their last known well was 6 o'clock. And I'm like, what time did they wake up? 6 o'clock. And I'm like, well, that technically is not their last known well. Their last known well is when they went to bed. And so unfortunately, all of that time that they were asleep is going to be counted against them, even though we don't know when exactly during their sleep they were having, the stroke come on. So what about a patient who saw their daughter at 1600 and then sent a text to their son saying good morning later that evening? Yeah, so it's gonna be 1,600. So that some family will be like, oh, but they texted me, but the text doesn't really make sense. But they texted me, so they technically, family will try to like convince you that that their last name well is not actually when it is. So you just have to be aware that what you can take as a last name well, what you can't. And then what about a patient who saw their son around 1700, spoke to them on the phone at 2100, sounded normal, was able to carry on a conversation, didn't have any complaints, and then awoke at 8 a.m. with deficits? Who said that? Yeah, so it's gonna be 2100. So sometimes we will actually take a phone call if they're able to, if they're actually like conversing with family, don't have any complaints, sound very normal. Sometimes it's gonna be up to the like neurology team's discretion, but sometimes we can actually take a phone call over actually like having to physically see someone as a last known well. And so sometimes you can get family to actually like show you what time they spoke to them. Obviously don't delay, like if family's like, oh, it's gonna take me 15 minutes to locate this time, just, get their phone number and we can kind of corroborate that, but, and get an estimate, but, just something to think about. And then what about, I don't have this one up here, but it's one that I've, heard several times. What about a patient who developed deficits, let's say, at 6 a.m., they got better, totally better, at, 8 a.m., and then around 10 a.m., they got, like 10 a.m. So they all of a sudden all of their deficits have resolved. It's going to be the last known well is going to be the time that they had the current onset of deficits. If they have complete resolution, none of that time counts. So that's confusing also, but they probably were having like a TIA, which can sometimes happen before an actual stroke. And so that's probably just something that was kind of like leading into their stroke, but it doesn't actually count against them because they totally resolved to their normal and then develop symptoms again. The contact number, we kind of touched on this already. Super, super important to get phone numbers just so that we can call, get the information that we need. If there's, something that they couldn't tell you and they were able to gather that information during transport, we can call and get more information. We also need them to be able to consent for the patient if the patient cannot. And so neurology oftentimes is like running around looking for numbers just because, to give like lytics as well as to do thrombectomy, they want to get consent and they want to talk through things and corroborate history. And so it's really important that we have a phone number of someone that is, like next of kin or can help get in touch with next of kin to make these decisions. And then checklist. This is a checklist that I know that we have that y'all fill out and leave with a patient. And so some of the questions on here, history of stroke. Do you have a brain tumor? Do you have an aneurysm? Do you have like an AVM in your brain? Are you pregnant? Have you ever had bleeding disorders? Have you had surgery? Are you on blood thinners? All these questions are super important. Why? Yeah, so lytics. And so we're kind of you're rapid fire asking them questions to see if they're going to meet inclusion criteria to get lytics. And so a lot of these are the questions that we're going to want to know before we give someone lytics because we don't want to, cause a bad outcome by giving them the medication. Then obviously you got your last known well time on there. That's that level of consciousness, alert, responsive voice, responsive pain, unresponsive that we've already talked about. And obviously blood sugar, always get a blood sugar. And so now we'll talk a little bit about how you're going to triage these patients, like where are they going to go? And so once you do your HEMSI score, first you're going to, level of consciousness, can they get an HEMSI? And so if they're in that A or V category, alert or responding to voice, then you can do your HEMSI. From there, you're going to see if it meets criteria for severe stroke, which is HEMSI 4 or more. And then you're going to see if their last known well is within 24 hours. And if it is, that's when you're going to go to the stroke severity-based triage, which you can see on the left side. On that side, it's going to be where are they going to go to a thrombectomy center? Or are they going to go to just like a stroke center where they can somewhere that they can get lytics? And so you're trying to make that decision, you'll be, calling TCC and they'll be kind of helping you with all of this. But that's really going to depend on how long is it going to take you to get to the thrombectomy center, right? If it's going to take you 2 hours, then we probably should stop somewhere and do lytics if they're within the window, in order for them to, have something on board to be helping them. And so that's kind of going to be your designation of, can you get to a thrombectomy center within 60 minutes, or do you need to go somewhere else with this patient? And so thrombolytics, how do they work? A lot of people just think of this as like a clot buster. And so you give it, boom, clot goes away. Great, the patient does better. Specifically how it works is TPA kind of goes in, binds plasminogen, turns it to plasmin, and that starts breaking down the fibrin. So you have all those fibers in the clot that's kind of holding all the platelets and things together. And so what you do is you're actually like breaking down all of that fibrin that's in there to allow the clot to degrade. So that's just a little bit of information on how it actually works. One thing that's important with TPA is that actually the size of the clot matters. And so the bigger the clot is, the less chance it's going to work, which makes sense. So if you have like a smaller clot, you're more likely to get that vessel to open up with the medication than if it's a very, very large clot, which I think, makes sense. And this is just kind of showing as the clot gets bigger, the odds of you actually opening up the vessel get smaller. So these are the patients that can get lytics. So who gets them? It's going to be the people who actually have a functional, like a deficit that's going to impact their quality of life. And so if someone, can't feel the back of their hand and that's all they have from their stroke, do you think that they should get lytics? Probably not, right? Because the back of your hand, what do you need that for? Not really a whole lot. And so the risk would outweigh the benefit in that case. So it has to be something that's actually going to impact your functioning. It's not going to be just like little tiny deficits that aren't going to impact their life. Obviously, last known well less than 4.5 hours, we say, is the cutoff to give lytics. Time is money with lytics, and so we really want it to be within 3 hours, but we can give them up to 4.5 hours. Adults only, so people over the age of 18. We're not giving lytics to kids. And no contraindications, which those are numerous. I don't know if y'all have seen the contraindications for lytics. We're going to like kind of quickly hit through the highlights of them, but there's a lot, and so we'll kind of talk through that. And like I said, time to treatment matters. So the two big lytics, TPA and TNK. Do y'all know if like you're primarily giving TNK around here? Y'all heard anything? A lot of people are making a big switch to TNK. UAB has switched to primarily like TNK now. And so basically, the big thing with these medications, like I said, is going to go in, try to start breaking up the clot. TNK is actually more specific, and so it'll preferred. It also doesn't have to be reconstituted. So they don't have to go to the the med room, mix it up and all that to get the medication administered. It doesn't have to be reconstituted, and its half-life is longer. So it's a half-life of 14 hours, and so that's why a lot of places have preferred TNK. It also has a comparable safety profile, and so considered to have about the same adverse events as TPA. And so a lot of people have kind of shifted to TNK. Big things here. What have y'all heard about blood pressure and lytics? Y'all know what the goal is? Like if you were transporting someone, they went to a hospital, they got lytics, but now they're going to a thrombectomy center. Where do you want their blood pressure? Is that one more time? So sort of. So you don't want it over like 185 or 110, 185 over 110. And so that is going to be like a contraindication to lytics if their blood pressure is that high. So once they've gotten the lytics, you're going to bring them down. So you do want to allow for like permissive hypertension in these ischemic strokes to the point that they get lytics. And so at that point, you're going to bring them down below this range because you don't want to cause more risk of bleeding from the lytics itself with higher blood pressures. And so that's why you're going to kind of keep that blood pressure lower than 185 over 110. So, like I said, tons and tons of absolute contraindications to lytics. Mostly, this is things that you would think about anyways. So risk of bleeding. So do they have a higher risk of bleeding? Obviously, you don't want to give patients who are at risk of bleeding something that's going to make their risk go up. And so if they've had, any head trauma or stroke within the last 3 months, if they have all these, intracranial issues like an ABM, an aneurysm, they've ever had an intracerebral hemorrhage, they don't get lytics. If they've had, like a puncture of an artery somewhere that can't be compressed, you're not going to give them lytics. If they sound like they're having a subarachnoid hemorrhage, but they have some sort of deficit, they're not going to meet criteria for lytics either, because sometimes if it's been a certain, it may not be seen on the CT head as well. And then obviously if they're on blood thinners and they're therapeutically anticoagulated, so they have labs that indicate that they're at a therapeutic level of anticoagulation, they're not going to get lytics either. Some of the big relative contraindications, so these are things that you want to think about whether or not you're going to give the lytics, but it's not an absolute hard line of giving it. And so this is patients who are pregnant, so you can still technically give it, but it's something that you really want to think long and hard about before you do it. If they're having if they've had a seizure, and then post-ictally they have this focal neurologic deficit, is that Todd's paralysis, which is where you can get unilateral weakness as a result of your seizure, or is this a true stroke? That's something that you want to be thinking about. Or if they're rapidly improving without the lytics, and you're thinking that they may, resolve without any treatment at all, that's something that you want to be thinking about. And then recent GI or urinary hemorrhage, obviously they're at risk for bleeding with that as well, but it's not an absolute contraindication. Major surgery within the last 2 weeks, or a recent heart attack within the last 3 months. So obviously y'all aren't going to be making the decision on whether or not to give lytics, but if you hear some of these, key history points when you're picking up the patient, or they say something to you, it's good information to pass along once you get there, just so that we know that they have, a relative or an absolute contraindication to lytics. And then some relative contraindications are only applicable from the 3 to 4.5 hour mark. And so that's these here. So older individuals over the age of 80, if they are on an oral anticoagulant, but they're not therapeutic, that's another time that you want to be thinking about whether or not you truly want to give it. If the stroke is super severe and their deficits are really significant, like we talked about earlier, big strokes don't really do as well with lytics because the odds of you actually opening up that vessel from that big clot are lower. And so that's something you want to be thinking about. And then ischemic stroke and diabetes is also, or prior ischemic stroke and diabetes is also a relative contraindication at the 3 to 4.5 hour mark. So obviously, if you give someone something that can make them bleed, they can bleed. And so one of the biggest complications that you see when someone has lytics on board is going to be bleeding, including into the brain. And so you can see some pictures of some hemorrhage, bright white is blood on that side of the screen. And so if you're transporting someone, like I said, who's gotten lytics and they start having a weird new deficit that you're seeing, this is something to be thinking about. Maybe this is going on. So just, maybe that's the time that you would want to call ahead and just be like, hey, this patient's doing this now, just so you're aware that wherever you're going. And then obviously I'm not going to go through all that, but you can see at the bottom, the big square bradykinin. So that's actually you lead to that. And so you can get angioedema with these patients too. So if you're riding in an ambulance with them, transporting them to get a thrombectomy, and then all of a sudden they do start swelling in their tongue, obviously that's terrifying, and another reason that you may want to call and see what they want you to do. And thrombectomy, like we talked about, some patients are a candidate for this. They actually have really strong outcome data for thrombectomy. I've seen patients even up in, in their 80s go for thrombectomy and have total turnaround. And so what they do is they take this, I don't know if you can kind of see that metal stent looking object that's going through the clots. They actually go through the clot with what looks like a stent. They expand it, open it up, and then they pull it out. And so that retrieves the clot from the vessel and hopefully opens up that artery where they're having ischemia. And this is only for patients who have had a last known well of less than 24 hours. And so again, another reason why it's important to know when their last known well time is. So how many of you feel super comfortable about like blood flow to the brain? It's complicated, right? And so there are some specific stroke syndromes that if you can recognize them, certain ones indicate large vessel, but your HEMSI is actually pretty good at distinguishing large vessel from like a smaller vessel occlusion. But we can kind of go through the different stroke syndromes and what they look like, because I guarantee you've probably seen one before, and the big ones of like don't miss these. And so we'll localize our lesions. So let's say we have a patient who has severe weakness in their left lower extremity and a little bit of weakness in their left upper extremity, but they can't hardly move their left lower extremity at all. And they're just like flat affect. They're not really acting like they care too much about the fact that they can't move their leg. What HEMSI score would you give this patient? We're going to give them, they have a lower extremity deficit. They have an upper extremity deficit. So it's really like a 2. So not really flagging as a like 4 or more, which we would look for like a large vessel. And so this is going to be anterior cerebral artery stroke. And so it's kind of, you can see it pointed to up there in the corner of the screen. So this is going to be a stroke somewhere in that area that's causing them to have, there's a good picture of it. And here you can see it in the yellow. So it's kind of like frontal cortex and then kind of on the middle of the brain. And so what that is, you know, a lot of your personality comes from your frontal cortex. And then if you look here, this is kind of a terrifying picture that they show a lot us in medicine. But this is where your motor function lies as you come from medial to outer brain. And so more leg in the middle. And so that's why their lower extremity is weaker than their upper extremity. And so that's pointing to an ACA stroke. What about a patient with right gaze deviation? So they're just looking straight to the right side. They have entire left side weakness, and they're not really paying any attention to the left side. They won't even look that direction. What HEMSI score would you give them? They're not looking over. They have arm, leg, and facial. And so that's going to be a 4, which I think one of you said. And so does anyone know where this stroke is? This is one of the big ones of can't miss. It's going to be your right MCA. And so something that I was taught in medical school is like they look towards the lesion. And so if they're looking to the right, it's going to be on the right side of their brain. And that's not always true, but it's like a rough rule of thumb. And so this is an MCA. So this is a patient that's going to qualify as a large vessel occlusion and have the potential to get a thrombectomy based off of their last name well and, you know, everything else. But this is one that you really don't want to miss. You can see the red there on the screen is the territory supplied by the MCA. And so that's what they've infarcted there. And the white, these are MRI sequences. So it's not blood, it's ischemia. And so this is like an MRI flare, but it just makes it easier to appreciate than it being dark. And so that's the area of the MCA that's infarcted. And so now we have a patient who has right-sided weakness, entire right side, who is looking to the left and is aphasic. So where do y'all think that one is? Say that one more time. Say left. 6. Oh yeah. So HEMSI 5 or 6, depending on if they can answer some of those like language questions. And then this is going to be your left MCA, another big one, another can't miss. And so I'm sure probably all of y'all by now have seen like the left side or the right side weakness in a stroke patient. Am I wrong? Has anyone not seen that yet? These are super common. And so these are your patients that you want to try to get to a thrombectomy center. And so just a couple more here. Let's say we have a patient who is confused. They can't see out of the left side of their vision. And they have this burning sensation along their right arm. I kind of gave you the IMSA there. This one is, they're not going to meet like flag high for like a large vessel. This one's kind of hard. These are your posterior cerebral artery strokes. So it's affecting your occipital lobe back here, has a lot of your vision. And so it's going to affect one of their visual fields. And so that's why they had that vision change. And sometimes you get like thalamic involvement. So they get this pain syndrome where they feel like they're burning on half of their body. And so that's your PCA strokes. And then just a couple more. And here's just an example of the syndrome that you see with these. This one's a terrifying one. And so let's say you have a patient whose eyes are open. They're kind of looking around, but they can't move their body. Sometimes even their diaphragm gets paralyzed in these patients. What do y'all think about that? Pretty bad. Are they going to score really high on IMSA? Probably not, because usually you're looking for unilateral signs. So you're looking for like the right or the, you know, if they can move like one side versus another. So they're probably not, because their whole body is paralyzed and they're kind of looking around. So this is locked in syndrome. I don't know if anyone's ever heard of that. It's like one of my biggest fears. I never want to be locked in. It's where you're locked in your body and can't move, but you can feel everything. So this is something that can happen with basilar artery occlusions, which is another one that is a large vessel occlusion, but these patients get sick fast. Sometimes their diaphragm gets paralyzed. Usually by the time we get there, they're not going to be responsive, so they're not going to be meeting IMSA criteria anyways. But that's that big artery right there that's going up into the brain, the basilar artery. And so when that's occluded, you actually get like brainstem effects from that. And so these patients obviously have a lot of deficits, and it's really scary. And I think this is our last one. So you have a patient who's dizzy, is falling to one side when they're walking. And when you're having them look side to side, you start to see that their eyes are kind of jumping around. Anyone have thoughts about that one? What about their IMSA? 0, right? So they're not really flagging for a large vessel occlusion, but this is going to be like a cerebellar stroke. So you have a lot of different arteries that supply the cerebellum. You can kind of see them sticking off there, as well as a vertebral artery occlusion can give you cerebellar strokes. And so here's your cerebellum. You can see that bright white area is all the area that's infarcted. And these patients are often sometimes even missed because they're just like, I'm really dizzy. This is that scary dizzy patient who's actually having a stroke. Most of the time, patients who say they're dizzy aren't having a stroke, but then every now and then you get one that is. And so this is one that you want to be careful to actually look for true like ataxia, meaning they're like falling to one side, or they're, not able to, like say they're trying to grab an object and they're missing it. That's because their cerebellum is affected. And so this is the dizzy patient that you don't want to miss. So overall, that's a lot. So that's really detailed. Those are, not always one size fits all. Even if someone has like a left MCA, they may not have all of those symptoms. And so that's what makes neurology so fun, right? It's that every patient is so different. But the biggest thing is you don't want to miss LVOs, right? So we don't want to miss the ones who can get thrombectomy. And then you have you can divide it into anterior circulation, meaning these are more of like your MCA syndromes plus, whatever else is affected. And so that's the ones with like the unilateral weakness that you're looking for. And sometimes they're, looking to one side, neglecting one side, or aphasic. And then, or your posterior circulation strokes, which are your basilar ones, which is going to affect your level of consciousness, can be that locked-in syndrome, or they have ataxia, vertigo, issues with like cerebellar things, so they're not able to balance. So you really just kind of want to look for those two syndromes, and if you can recognize those, you should be okay. And then you also obviously are going to be using your IMSA, and that'll help you out a lot. The hemorrhagic stroke, does anyone know what type of hemorrhagic stroke this is? like a crescent shaped, if you can see. So it's kind of concave all the way around the edge of the brain. So that bright white area over here is your blood. And so that's going to be your subdural. And so these patients get tears in the bridging veins. And so that's why it actually has a crescent shaped, because it can cross all the way around the skull. A lot of times we see this in our elderly patients who are like the fall. Everybody has to alert these fall from standing people. And we get a lot of subdurals from that, or alcoholics who have just been falling a lot. Sometimes people will come in and they have a subdural and don't know it, and some people are super symptomatic, and so that can be really scary. This one, can everybody appreciate the blood there? Kind of in the middle, a big cloud-looking thing. And so that is what we would call like an intraparenchymal hemorrhage. And so it's like in the parenchyma. A lot of times this is actually from like a stroke equivalent. And so these patients start to bleed into their actual brain tissue. Those patients have often like super, super high blood pressure when you get there to pick them up. This one, I know y'all saw this in Ferg's lecture, so does anyone appreciate the blood in this picture? You see the star of death? So that's your subarachnoid. So these are typically from that aneurysm in the brain that's ruptured and let blood all into that subarachnoid space. And so you can kind of see the little star in the middle of the brain, all that's blood. And then here we have epidural. So you can see like the lens appearance of it looks different from the crescent shape, right? You see how far the crescent tracks down, as opposed to the epidural, it kind of stays in that one spot, but it's really pushing into the brain. So these are really scary and can get really sick really quick. And so a lot of times this will be the patient that gets hit like right here on the temple. There's an artery that lies right behind there. And so if they get hit hard enough, that artery will rupture. It's the middle meningeal artery. And then it starts to just bleed under arterial pressure right into that space. And so then the blood starts to push over onto the brain. And eventually they can herniate and die. And so these are the patients that actually may go straight to the OR with neurosurgery or to get, like a cranie, get part of their skull taken off and that clot evacuated. So a couple of things with hemorrhagic strokes. What about blood pressure in these patients? Talked a little bit about blood pressure in ischemic stroke. So we're going to let their blood pressure kind of ride high to let them perfuse their brain the best that they can until they get lytics, and then we're going to keep it under 185/110. What about the patient who has, blood in their brain? Yeah, so we're going to keep it low. And so these are the patients that we're going to actually bring their blood pressure down. But that's not going to be something for y'all to do because y'all are going to be without a CT scanner, right? We have the luxury of being able to scan them and see what's going on. Y'all don't have that. And so usually for y'all, I wouldn't be making any decisions about blood pressure in these patients with like stroke-like symptoms. I would let them do that once they get imaging at the hospital. That's all I have. Does anyone have questions? Feel free to come and talk to me after if you do.
Hey, Dr. Adams, we got a couple. One was back on the contraindications of TPA. One of the contraindications I think listed was myocardial infarction within the last 21 days. Yeah. So any explanation as to why that would be a contraindication?
I think it's probably due to the antiplatelets that they're on the DAPT therapy. And so you don't want to splice someone who's already another, like I said, at risk for more bleeding. So they're already on dual antiplatelet therapy. So they're going to be on aspirin as well as like Plavix or Brilinta. And so those patients are already at risk for bleeding. And so you don't want to add on lytics on top of that.
Gotcha. So when we go back to hemorrhagic stroke, I'm assuming we'd see similar CTs for the same pathologies caused by trauma, right?
Yes.
The question was asked, we know that ischemic stroke is far more common than hemorrhagic stroke, but of the hemorrhagic strokes and associated similar findings due to trauma, what's the most common and what's the most rare? Epidural, subdural, subarachnoid?
Oh, Or you can correct me if I'm wrong, but I think most commonly, at least from my experience, I see either subdurals or subarachnoids more commonly from trauma. Primarily subdurals, I feel like. But sometimes you'll even get these patients who have like multiple types of hemorrhage. So it's not always just like one isolated type. And so usually I think that would be the most common. And then rarely do we see these epidural hematomas because you have to get hit at the right spots to cause the blood to be leaking in under arterial pressure. So that's different than under venous pressure. So arterial pressure, they're really going to be pushing blood into that space. Venous pressure, as you'll know, is much, much lower. So they're bleeding at a lower rate.
Yeah, I kind of asked that question on purpose because I've noticed over the years that in EMS it's actually the least frequent, but I don't have any real data on that. I just think it's interesting that there's a gap there between what we're teaching and what reality is. So very good. Dr. Ferg, do you have anything to add?
Yeah, no, I agree. I think when I think of strokes, I think of interparenchymal that kind of transition into a subarachnoid space or the subdural. When I think of blood in the head, if I think subdural or epidural, I'm thinking usually traumatic. And I agree, the subdural is probably the most common blood that you can see in the head because, you know, the older you get, your brain shrinks and it puts pressure on those bridging veins and small falls cause blood in the head. And there are probably folks that get subdurals and never go to the hospital even, right? So most common. I wanted to ask a couple things. For the HEMSI, she talked about we don't really use an HEMSI score if they're unresponsive or responding to pain only if they're alert or verbal. And the reason for that is because we want to identify these large vessel exclusions, right? So there are some strokes that you can have, like that basilar artery posterior stroke, that you can be completely obtunded, and you'll miss that by these rules. But the purpose of this is to get the people to the hospital that have ischemic strokes that we can fix. So 20 years ago, if you had a stroke, we gave you hugs, lowered your blood pressure, told you to quit smoking, and put you in rehab, right? And the outcomes were not good. We actually have medicines that can fix strokes. And like Dr. Adams was saying, I've seen some of these folks that have come in with a large vessel occlusion that go to the cath lab, get that clot removed, and 3 days later, they're back to golfing or doing whatever they were doing. It's crazy, the response you see to this. So that's the purpose of HEMSI, not to get all the strokes, but get the majority of the LVOs that we can. I had a locked-in syndrome stroke ischemic the other day at UAB that we picked up with our imaging, but that was somebody that would not get an HEMSI score because they were altered. So you can find those things, but the goal here is to capture the most patients that we can that have ischemic strokes so we can fix that. Hemorrhagic strokes, can't do a lot for those. Sad to say, but it's supportive therapy. It's important to recognize them, to manage those patients, but my thoughts are it's more important to make sure we catch the ischemic strokes because we can treat those.
And Dr. Ferguson, you know, I always bring this up. In the pre-hospital setting, before the patient gets scanned, there's no reliable way to tell the difference between hemorrhagic and ischemic. Would you agree with that statement?
I would say there's no definitive way. I've been burned with that. So you think headache, stroke symptoms, unilateral weakness that becomes more obtunded and altered and unresponsive. I'm thinking probably hemorrhagic because it's getting worse, right? But I've been burned with that. So that's why I argue we don't do blood pressure control in the field until you see a scan. Because if it's a hemorrhagic stroke, you want to lower the blood pressure to decrease the bleeding to a degree. If it's ischemic, you want that blood pressure to ride as high as you can let it go within reason to improve collateral circulation until you can lyse them or get them to the LVO. So just you don't want to make patients worse. The other thing we talked about is last known well. Super, super important to get that information. One of the reasons is, if we give somebody TPA or TNK, a clot buster, right? If we do it within the 4.5 hours or even 6 hours, some places, the goal is to make that clot go away and restore perfusion to the brain. All well and good. If we give them that same medicine at 8, 10, 12, or 24 hours, the risk is increased. Imagine, if you will, you got a clot in a vessel. Everything downstream from that clot in the brain is ischemic. So the blood vessels distal that get weak, they start leaking, the brain starts dying, okay? You only have so long before that's irreversible. You give somebody a thrombolytic 8, 10, 12 hours after that event, you're going to actually change that ischemic stroke to hemorrhagic, because if you clear that clot, everything downstream leaks and now they bleed and they can die from that. So just huge risk to these medications if we don't give them right. So that's the big important thing. And that's why, like Dr. Adams said, please try to get a phone number. I don't know many neurologists that will give someone TPA, TNK, or do a thrombectomy if the patient's nonverbal without talking to somebody. So there's we got to get that number for those folks. What else do I have? Who does the checklist she showed? It's in the state protocol. Anybody do the checklist and give it to the hospitals? Raise your hand if you do, and I got a $100 bill for you if you do. Yeah, nobody does that. My advice is, state says we should do that. I would advise you at least get that information. You pass it on to the hospital. If you can't print it off, no harm, no foul. But that information, that checklist, the glucose, last known well, family phone number, and that screening for lytics is super important, guys. It saves minutes, and sometimes that is the difference between licensing somebody and them not getting licensed. Cool. Other questions? We got docs in here. Do y'all do LVO? Where y'all do LVO? Just Huntsville? Okay. Perfect. Yeah. Yeah, perfect. That's fantastic. So yeah, it is huge. Yeah. And yeah, it's unreal, the results. Yeah. The key is use TCC, get the information, the data they need, make it efficient, and they will direct you where to go, who's available, and use the system as a whole. Cool. Anybody else? Questions, comments, statements within reason?
No, I think it's really important for everybody in EMS to realize a couple of key points here. One is that the HEMSI scale is really designed to identify large vessel occlusion strokes, LVO strokes, that can be helped at a thrombectomy center. That's really the point of it. Would you agree with that, Dr. Ferguson? That's really central. And
Yeah.
we're not saying if they don't have a high HEMSI score, they're not having a stroke. We're saying they're not necessarily a good candidate for the thrombectomy procedure.
Correct, right. And you have other hospitals that can do the CT scan, make the diagnosis, and LifeSlim. You even have some freestanding ERs in our state that can do that. All right. And that takes the load off the hospitals that can do the large vessel occlusion thrombectomies, so they can manage the larger ones. And then once they get them cleared out, take the other ones in. So use the system. It's fantastic.
TCC is really key to that.
Yep.
Calling TCC when you recognize a stroke patient, doing the HEMSI scale as accurately as possible, making sure that you are gathering the information on the scene that may only be available on the scene to make the physicians at the hospital comfortable with either lysing or doing thrombectomy. That's all part of being an advocate for your patient, in my mind. I know it's extra work, but it's worth it. And then, we have to remember it's not always in the patient's best interest just to go to the closest hospital. Oftentimes, that's not in the patient's best interest, and that's where this system can play a role to getting patients to the right resources. So great lecture, Dr. Adams. We appreciate your lecture as always, Dr. Ferguson. You got a question, sir?
So the question was, if a patient has signs of a cerebellar stroke, there's not really a big EMSA number there. Is that still a stroke? Yes, you can put anyone you want to in the statewide stroke system if you think they're having a stroke. and you can be directed to a place. If they don't have that high HEMSI score, they probably will not direct you toward a thrombectomy center. They'll get you to an ER that can scan them and make that diagnosis. And if they need to be licensed, they can. And then because they're in the stroke system, it makes it easier for that community ER doc to transfer to a higher level of care. So yes, if you think they're having a stroke, call TCC, put them in under EMP discretion, and explain why. And sometimes you'll be right with that, right? Just like the one that I had the other day that was a locked-in stroke, right? Would not have been a high HEMSI, right? But you can still put them in the system, go get the evaluation, and if the call is correct, move them up the food chain. Cool. Yeah.
Very, very good. Great question.
And don't forget the easy things, the low-hanging fruit. These folks that are altered that you think may be a stroke, you know, get a glucose, get a good history, find things that we can fix first so we aren't tying up the stroke system for things we don't need to if we don't have to.
Yeah, and realize there's still a high level of over triage in the stroke system, and that's acceptable. And the patients who are being triaged into the stroke system who aren't actually having a stroke are usually at least interesting that need neurological care. So thanks everybody for participation today. Special thanks to Aero Region 1 and Calhoun Community College for sponsoring us today. We had a great venue. If you're in the Decatur area, come by and eat lunch with us. We'll have skills lab after lunch. If you're listening online or in person, please remember to fill out an attendance form. Even if you don't need the CEUs, you can get the link on the Q&A box. I'll be showing the QR code for a while after we end the meeting here in a minute. If none of that works for you for whatever reason, you can always send an email to alabamaemschallenge@gmail.com. You'll get an automated response with a link to the attendance form. The password for today's form is stroke, all lowercase. And hey, Doc, where are we going to be next in June? We're going to Birmingham Fire second Wednesday, and then we'll be out in East Alabama, I think, in the fourth Wednesday. So look forward to seeing everybody then. Thank you, and that's a wrap.